స్టార్ట్ అయింది. నేను మెయిల్ చూసుకోను మీరు మెయిల్ ఓపెన్ చేసి చెప్పేసి
Good morning, everyone. Stop here. Good morning, everyone. Last week we have seen about chronic liver disease, like chronic hepatitis leading to chronic liver disease, that is cirrhosis, and its complications and management of its complications. So this week we are going to see about the acute hepatitis part, the hepatitis part actually, acute and chronic both. Like how does hepatitis present to you, what are the causes of it, and in this class we are going to discuss about the viral hepatitis part. Okay, so what is hepatitis? It's the inflammation of liver by any reason. If there is liver inflammation, you call it hepatitis. So what are its causes? Causes can be, what all causes inflammation? It can be metabolic injury, it can be toxic injury, it can be infection, it can be autoimmune disease. Any of these can result in inflammation of a particular organ. In liver, the etiologies are infections like viral, bacterial, fungal, and parasites. And non-infectious agents, most important are drugs. Drugs cause hepatitis, mostly paracetamol and other like anti-epileptic drugs, all can cause autoimmune diseases. Metabolic diseases we have seen in the last class, like hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency. All of these can cause metabolic cause. Just a minute. So in this class we are going to deal about viral hepatitis. What are the most common causes of viral hepatitis? It's hepatitis A, B, and C. In pregnant women, viral hepatitis E is common. Hepatitis D is also prevalent, but it is not per se a virus that can cause hepatitis. It only works when there is hepatitis B infection too. So most important are A, B, C, and E. In this class, we are going to discuss about A and B. So there are also other viruses which are not hepatotropic. They per se don't infect the liver, but usually they infect many other organs, and in part of that they infect liver also. And examples of them are cytomegalovirus, Epstein-Barr virus, and herpes simplex virus. Hepatitis A, B, C, D, and called hepatotropic virus because they grow in the liver, not in other organs. They may be present, but most importantly, they grow in the liver. So hepatitis is pretty simple and straightforward. It's a common cause of diarrheal illness in India. So hepatitis A virus is a non-enveloped RNA virus belonging to Picornaviridae. It is through fecal-oral transmission. When there is groups of people living together in low socioeconomic and low hygiene conditions, that contaminated water through fecal-oral fluid will cause this infection. Clinical features can be just the patient can be asymptomatic, the patient can have a diarrheal illness, just a diarrheal illness, or the patient can have hepatitis and jaundice also. And sometimes this can lead to fulminant liver failure, acute liver failure it can result in. But usually it is asymptomatic or just a diarrheal illness. There is no chronic state in this in the hepatitis A. Hepatitis A doesn't persist for long. It usually resolves within 15 to 30 days. Okay, complete recovery is seen. So treatment is generally supportive management, and Whenever some person in a household is infected, we isolate the patient. We ask them to wash their hands. Proper isolation should be maintained, and mass awareness is usually the way to prevent this. So vaccination, it's actually to prevent this vaccine. It's usually given in debilitated patients or in Western countries. In India, the vaccine of hepatitis A is not so common. We usually get infected and the infection subsides. But in Western countries, they usually vaccinate for this. We also vaccinate for hepatitis A when the patient already has a chronic liver disease. So any other infection might tilt the balance, uh, might make the patient worse. Any patient already suffering from a liver disease, if he gets hepatitis A, patient may go decompensated, go to decompensated liver disease. So in those patients, we might consider giving vaccination. But in India, it's usually not so prevalent. That's about it. So the most important part of our today's class is hepatitis B. Okay. So I think it's streaming. It's having some problem here. Yep. So coming to hepatitis B virus, it's the most important virus we are dealing with in this viral hepatitis. It's a DNA virus. It's a double-stranded DNA, but partially open. So one strand is not completely formed. One strand, it's a circular DNA. One strand is totally formed, it's like a circle. The second strand is partially open. It's not completed. Okay. It's an enveloped DNA virus. The envelope is derived from host cell membrane actually. Whenever the virus buds, it takes up the host cell membrane, host cell lipid membrane, and forms an envelope. And on envelope, some viral proteins are also embedded. Okay. So it belongs to the family Hepatidinaviiridae. Mode of transmission is usually parenteral, sexual, and perinatal exposure. Okay, perinatal exposure is most important for children. Sexual transmission and parenteral transmission is for adults. So there are 8 genotypes in different locations. The most common in Asia is B and C. In India, the common thing is C. Okay, that's what you need to remember. So coming to acute hepatitis B infection, how does it present? I'm not going into details of the structure of hepatitis B virion, like how it replicates, how it transmits, and all, because it's all covered in your pathology already. Now I am going to deal about the medicine part of it. Okay. So how do adults get the infection? It's usually by parenteral and sexual route. It's highly infectious, more infectious than HIV actually. Children usually get it from infected mothers, already infected mothers. So acute hepatitis B infection, the incubation period is 40 to 150 days. So what are the symptoms that it's going to come with? Usually the patient will have fever, anorexia, fatigue, malaise and nausea, not jaundice initially. All these fevers are like a viral illness. You will have fever, anorexia, fatigue, joint pains, nausea and all. But as soon as the fever subsides, within a week the fever tends to subside, okay? And suddenly you will start having jaundice. Jaundice usually comes after fever in hepatitis. If jaundice and fever come together, you should look at other diseases like leptospirosis, malaria, and cholecystitis, choledocholithiasis. All these you need to look into. But here you need to see that a fever subsides in a week or two, and then jaundice arises. It's classic case of hepatitis. So 1 to 2 weeks later, patient develops jaundice, hepatosplenomegaly, pruritus, and intense fatigue that will last for 1 to 2 months. So these patients will have prolonged symptoms for 1 to 2 months, and during these symptoms, the hepatitis may be mild, moderate, or very severe. The hepatitis B is very severe. The patient may go into acute liver failure. If not, the patient will just have jaundice and all this uh, systemic symptoms like anorexia, nausea, vomiting, and all. If the patient goes into acute liver failure, the patient will have hepatic encephalopathy, hepatorenal syndrome, ascites, all these kind of symptoms. Okay. So acute liver failure is kind of rare, occurring in 0.1 to 0.5% of cases. So what happens to acute hepatitis B infection? I'll tell you just in a few moments. So the next is chronic hepatitis B. So if this acute hepatitis B doesn't resolve within uh, 6 months, you call it chronic hepatitis B. This also ranges from asymptomatic to symptomatic. Patient will have ongoing hepatitis, but the patient will not have jaundice or any symptoms in case of asymptomatic people. But in symptomatic people, they'll have jaundice, they will have signs of liver failure ongoing, and also it can lead to cirrhosis. Cirrhosis can also be present along with hepatitis in these patients. So how so when do the patients will get how do patients get chronic hepatitis B? If the patient gets infected in childhood, mostly within the first 5 years of life, or perinatal medicine class. ఉదయ్ కిరణ్ నేను వచ్చి ఓకే నేను వచ్చి చెప్తానండి అక్కడికి వచ్చి. So where are we? So the chronic hepatitis B usually occurs when the patient acquires the infection in childhood. Okay, when they acquire the infection within adulthood, usually the patient goes into acute hepatitis B and it resolves. Okay, so what is chronic hepatitis B? So we have already seen it. Chronic hepatitis B will usually lead to cirrhosis. So which patient will have only acute infection, which patient will have chronic infection, and how many patients infected acutely will progress to chronic infection? That is what we are going to see. Okay, not this slide. See, for example, if the patient acquires acute hepatitis B in adulthood, the patient has got through sexual or injection abuse or blood transmission somewhere, or injection injury. Doctors usually get through needle stick injuries. So if the patient gets acute infection in adulthood, 95% of these infections resolve within 1 to 2 months. You need not worry about them. They are not infective and they are resolved infection. Only 5% will progress to chronic infection. Whereas somebody acquires the infection through her mother, only 10 people have resolved infection. 90% will become chronic. And how they progress, what happens to them, the lower part of the slide we are going to discuss later. If you acquire somewhere in early childhood, 20 to 50% of patients will go into chronic infection, and 50 to 80% they get resolved infection. That means if you have seen a trend here, the earlier you acquire the infection, the more chances you get you progress to chronicity of the infection. Okay. So see, perinatally acquired infection. Risk of infection that you acquire perinatally when the mother is infected is when the mother is HBeAg positive. What is HBeAg positivity and all? We'll see within few minutes. Okay, 90% of risk. If the mother is HBeAg positive, 90% there is a chance that the child will get the infection. If the mother is negative, there is 20% chance that the child will get infected. What are the phases they are going to? I'll tell you later. Okay, so as I told you, as a child grows older, the risk of chronicity decreases. The patient will have symptoms like we already told, that acute infection symptoms, anorexia, nausea, vomiting, followed by jaundice. So what are the extra hepatic manifestations? Are migratory polyarthritis, angioedema, urticarial rash, glomerulonephritis, papillodermatitis. All these are immune reactions. Okay, when there is immune antigen antibody complexes depositing in your blood at different parts of the body, you'll have these kind of reactions. So how do you diagnose a hepatitis B infection? It's the serological assays. When dealing with serological assays, I will also describe you the pathogenesis of the disease and all. So here, this is C. Forget about the chronic hepatitis B part. We'll be dealing about acute hepatitis B here. So patient has come to you with fever, nausea, anorexia, and fever, followed by jaundice after 1 week. So this patient you are suspecting hepatitis B, viral hepatitis. You have done serological test for hepatitis A, and now you are doing for hepatitis B. You want to find out if the patient is having hepatitis B. To know this, to understand this, you need to know how the antigen antibodies behave in the blood. Okay, here is the slide that helps you understand what are the serological tests that you do. Usually when a patient comes, you do hepatitis B test before a surgery. You want to know that the patient is having hepatitis B so that you don't get infected when operating on the patient. So how do they work? See, HBsAg, here you are seeing this red line here. This is hepatitis B surface antigen. It is present on the envelope, okay, envelope of the virion. So when this is present in the blood, you know the patient is infected, okay. uh, and antibody to this is anti-HBs, anti-hepatitis B surface antigen. When this is present in the blood, you will understand that the infection is cleared, okay. So you must understand some basic concepts here. Whenever there is antigen and antibody, they both neutralize each other and you cannot identify in your tests, okay. You need to have either free antigen or free antibody for you to detect either of these. If either of these are to present in equal quantities, they both get neutralized and are not detected by any assay. Any test you do, you cannot find them unless, say for example, take this as an example. You have 10 antigens and 5 antibodies. 5 get neutralized because you have 10. 5 of the antibodies and 5 of the antigens get neutralized and you have 5 antigens remaining. These can get detected. But if both are 10 and 10, you will not detect them. And if you have 5 antigens and 10 antibodies, five of each will get neutralized and you'll have 5 antibodies that you can detect. Understood? So initially when the patient has infection, the antigen is more, virus is replicating, you'll have so much of antigen. So you'll detect this red line here, hepatitis B surface antigen, within 4 to 8 weeks of exposure. And suddenly body realizes there is an infection and mounts an antibody response. Antibodies gradually start increasing. See, somewhere around here, around the peak, you'll start having antibodies. And so they neutralize these antigens and slowly the antigen titer comes down. Okay, antibodies keep increasing and they keep neutralizing the antigen and the antigen comes down. At this point, there is no antigen. And after some time, your antibody titer increases even more, and at this point, you will start detecting the anti-HBs antibody. Okay, see this is antigen HBs AG. You will detect with up to 24 weeks, and after that, within few weeks, you will also have antibody. Antibody has not started here. Antibody has started somewhere here, but you only detect here because both are getting neutralized. So there is a window here. See, 24 to 30 weeks. You neither have an antigen nor have an antibody. In these 4 weeks, you don't have anything. Does that mean the patient doesn't have infection? No, the patient has both HBs AG, HBs antibody he also has, but both are getting neutralized and you don't detect. So how do you detect in this part? That's called window. There is a window during which you need to detect hepatitis B infection. You should not miss it. Okay. So how do you detect this? So here HBsAg is getting released into the blood and antibody is neutralizing it. But there is one antigen that is not released into the blood. That is called core antigen. Hepatitis B core antigen is not released into the blood. It will be there in the liver cell only. But because our immunity recognizes it, an antibody is produced immediately. Anti-HBC is produced. But now, because the HBC is not really getting released into the blood, hepatitis B anti-HBC cannot get neutralized in the blood itself. So as soon as the patient gets infected, you will start detecting an antibody because there is no antigen in the blood to neutralize, to mess up with your blood test. Okay, so see here, this blue line, blue and yellow line, you will start immediately detecting the anti-HBC. So even when there is HBs antigen present and no anti-hepatitis and HBs antibody, you will start detecting the anti-HBC. So this is the first antibody you see in hepatitis B infection. So see this yellow line, this is present even during the window period. So in this, where some patient has come with fever and jaundice, we did HBs AG, patient is not positive. So what do? You do anti-HBC. If that is positive, patient is having acute hepatitis C. Okay. And apart from this, you will also have hepatitis B antigen and anti-HBe. Okay. During the infective, this is called pre-core antigen. HBeAg also will have. So this shows the seriousness of the infection, the replication. If there is more HBeAg, there is more hepatitis B replication in the liver. So as soon as the anti-HBe starts appearing, this HBe will also disappear. See, this is the part where you'll have anti-HBe. And this symptom, this part, where you'll have both antigen and antibody, this part from here, see from this peak till here, you'll start having symptoms. Why that? I'll explain you later. Okay. I hope I'm clear till now. Whenever there is an antigen, you will not find an antibody, and whenever there is an antibody, you will not find the antigen because they both get neutralized. In case of anti-hepatitis B C, there is no antigen releasing into the blood, so you'll immediately find an antibody. Okay. Sorry. So HBeAg shows the infectivity. If it is more, HBeAg is more. If HBeAg is detected, the patient is more infective. So coming to this slide. So now we are talking about acute hepatitis C. Okay, hepatitis B. So as you have seen, hepatitis surface antigen is positive when there is acute hepatitis B. Hepatitis B antigen is also positive, and as I said, I first antibody to appear IgM is positive. This IgG and HBC anti-IgG will take a lot of time to appear, and by the time the patient has recovered. So in early, you will see only IgM, but when the patient has already recovered, you will see IgG here. See, this is the recovery phase. You will have when the patient has IgG, anti-core IgG, that patient has already recovered. Okay. So in recovery, the HBsAg has disappeared, HBeAg has disappeared, core IgM has disappeared. What has appeared? Antibodies have appeared. Antibody to HBs and antibody to HBe have appeared. Okay, this is the recovery phase. I hope you understood. I don't get a feedback when I'm teaching online, so pardon. So this is how acute hepatitis B behaves. Okay, whenever there is an antigen antibody reaction, you will start having hepatitis. When you have hepatitis, what will happen? How do you understand? We'll see clinically that there is jaundice and all, and then you do lab parameters. How do you do? What are the laboratory parameters you check? You check for liver enzymes, ALT, AST, alkaline phosphatase, ZGT, albumin, PTINR, prothrombin time. All these you check. So these are all the liver functions for this you check. And when liver enzymes are elevated, usually in acute hepatitis they're elevated to thousands. Okay, 4,000, 5,000 you see. And if it is very severe, liver synthetic function is deranged, and you'll also have coagulation abnormalities. So that is how you detect using serological tests and biochemical tests that there is acute hepatitis B. What is the treatment for acute hepatitis B? Usually there is no treatment. You maintain symptomatically, you may give supportive treatment. The patient usually resolves in 95% of the patients. The symptoms usually resolve within 2 weeks, and the patient is all right. But in very severe cases, fulminant hepatitis, you can give antiviral drugs. So coming to chronic hepatitis B. So as we have already seen, chronic hepatitis B in adults only 5% progress to chronic hepatitis B, but in children 90 to 95 actually progress to chronic hepatitis B. How does chronic hepatitis B behave? Okay, why does they grow to chronicity actually? Because of their immune system is not capable of clearing, or their immune system don't want to clear the infection. In whom does this happen? In children actually. What happens in children is when they acquire this infection perinatally, our immune system kind of thinks that, oh, this is our own body, because this is present right from the birth. It thinks it's our own body, and it decides not to infect, not to attack that. So these patients will not mount an inflammatory response against the virus, and the virus persists for life. Life means up till 20-30 years. Whereas in adults, because you have newly acquired the infection, it thinks that it needs to clear the infection. Okay, in adults, it thinks that it needs to clear the infection, so you will have a reaction. Whenever somebody both fight, you'll have something to see, you'll have a fight. But some body decides not to attack, the virus will be happily growing as if it's a symbiont, and you don't even have a reaction. But it will have consequences later. I'll tell you how. So there are different phases of this. For chronic HBV infection, you call it immune tolerant phase, immune clearance phase, inactive carrier phase, reactivation, and all. What is immune tolerant phase? So whenever a child acquires the infection from the mother, the body decides not to attack this infection because it thinks it's part of our own. So this patient will have heavily replicating virus. Your HBeAg is very high, because HBeAg denotes replication, right? it has very high HBeAg titers, and antibody is not there. Anti-HBeAg is negative, and high levels of hepatitis B DNA can be detected in blood because of high replication. And because there is no attack of immune system on the liver cell and the antigens, you will not have liver inflammation and no liver damage also. So the patient will have normal liver function test, normal LFTs, no AST, ALT rise. So and even when you do a liver biopsy, there is no hepatitis. This is called immune tolerant phase. You tolerate the infection. So this you mostly see in children. Okay. In adults, what happens as soon as acute hepatitis phase is over? The immune system of the adults want to clear away this infection. It keeps on attacking with antibodies and all viral antigens on the liver. So what is positive? That HBeAg is still positive. The virus is still replicating, but the body wants to fight. HBeAg is still negative, but because you have not mounted sufficient immune response, you are still having inflammation, but the immune response is not enough, and hence you cannot detect the antibody in the blood. It doesn't mean the antibody is not getting produced. It is being produced, but you cannot detect it because the antigen titers are still high. So HBV DNA titers are also high. Now the difference between immune tolerant phase and immune clearance phase is here the LFTs are elevated because you are having liver inflammation. Hepatitis you are having at this phase, you will have elevated liver enzymes. So when you do a liver biopsy in this patient, it shows chronic hepatitis with moderate inflammation, necrosis and inflammation. Whereas here in immune tolerant phase, there is no inflammation or no necrosis. So this immune clearance phase will progress to can progress to not will can progress to inactive carrier phase. Now the body has mounted sufficient immune response, and because of the inflammation, the virus has been getting eliminated. Now virus is still present, but it is getting eliminated. So there is no antigen antibody complex formation. The hepatitis will start decreasing. The antibody has increased. It is effectively clearing the virus from the liver. So now the inflammation will keep decreasing. Now, so see what happens. So what is the marker for replication? Severe replication, HBeAg. So HBeAg has come down, and anti-HBeAg becomes positive. Okay. So now the antibody is positive. It is higher. So that will become positive. The HBV DNA, it will become low because the DNA is a marker of also marker of replication. So it has also come down. So and now the inflammation has also come down. Your also LFTs start normalize. Okay, the LFTs are normal. Liver biopsy there is no active inflammation, there is no hepatitis, but can have cirrhosis because of past injury. I hope you are understanding this because I don't have feedback what you are understanding. These are all important concepts to understand. So now inactive carrier, what happened is it has almost eliminated the virus. So the replication HBeAg, HBV DNA are negative. HBe antibody is positive. There are normal LFTs, and liver biopsy can show cirrhosis but not hepatitis. Okay. In this phase, your HBsAg antigen is still positive. HBs antigen, surface antigen, is not an indicator of replication. It's just a sign of infection. It's not an indicator of replication of virus. The indicators of replication of virus are HBeAg and HBV DNA. Okay. So see here. We'll see the next. We'll see this slide. Where is this slide? So see here. So this is a chronic infection. The patient has not eliminated the virus. This is how it behaves in adults, not in children. Okay. So here, see, in children, the immune tolerant phase, I'll show in a different slide. This slide shows the immune clearance phase and the inactive carrier phase. Okay. So here you see, as soon as the patient gets infected, your HBsAg is positive, like in acute. But instead of the acute infection from coming down here, in acute infection it started coming down from here, right? This has not happened in this. It keeps on being positive. Okay. And our anti-HBC has also appeared because it is the first antibody to appear, right? But anti-HBsAg has not appeared because the infection has not been cleared. Anti-HBsAg is not appeared, and HBAg, which is the indicator of replication, is always positive. This is all until here. It is the immune reactive phase. Until then, the immune system is reacting. Still, it is trying to mount an antibody response. The hepatitis B is still positive. You will start having inflammation. You will start hepatitis. As soon as anti-HBe appears, will start the clearance of reaction because HBeAg has decreased, but still the anti-HBeAg is positive. Here, see this, it's still positive, but the anti-HBeAg has appeared and HBeAg has disappeared. This is the immune clearance phase. At this point, you will start having decrease of liver enzymes. Okay, this is the immune clearance phase. Inactive carrier phase. Until then it is the immune clearance phase. Until here it is the immune clearance phase, and it is all, and from here it is the inactive carrier phase. Okay, so because of inactive carrier, the HBeAg is negative and HBV DNA titers are low, these patients are not as infective. So in whom this this slide, if you see, whenever the patient acquires the children acquire the infection, they directly go into the immune tolerant phase. See here, immune tolerant phase. They don't even mount a response. But after reaching adulthood, because the virus itself will start damaging the liver at that point within 20 to 30 years, because of the very high viral load, it will start damaging the liver. And at that point, some people will start recognizing that it is an infection, and the body starts attacking the body. So at that time, at 20 or 30 years of age, they will go into this immune clearance phase. Whereas an adult, they don't go into this immune tolerant phase, they directly go into the immune clearance phase. So what happens after once they reach the immune clearance phase? They'll go into inactive carrier. The HBeAg has disappeared, only HBsAg is positive at that point. And from immune clearance phase, they'll go into inactive carrier, or they can directly go. This may never happen, and they can directly go to cirrhosis. The immune clearance phase keeps on going, and the patient will never sufficiently mount an immune response, and they can go into cirrhosis. Some patients, after reaching the inactive carrier state, can reach here. From inactive carrier state, they can reach to reactivation. The patient again will have immune clearance phase kind of picture. Again, the virus becomes stronger now. He'll start having immune reactions, and he'll start having hepatitis. Okay, so from this they can go back to this, and when you go back to this, you call it reactivation phase. Okay, so cirrhosis, after having cirrhosis, they can have hepatocellular carcinoma or can have a decompensated liver disease and die. So coming here, you will see the replicative phase. Reactivation. So in these patients, what happened? The virus has grown stronger. Again, the antibody will increase. There is another way the patient will get into reactivation. So here, see, until now the replication antigen HBeAg is present, and the patient is mounting an anti-HBeAg, and it starts attacking the anti-HBe. Anti-HBe starts attacking HBe, and the virus will get eliminated slowly. But these viruses, after sufficient time, will have a mutation in HBe. They no longer produce HBe. Because they are not producing HBe, this anti-HBe cannot attack the virus because there is no HBe. See, for example, there is some person, you can say to him that, I'll take away your money, and you will blackmail him. The person suddenly loses all his money and he throws away all his money. There is nothing for you to do to him. You cannot take away his money anymore. So you cannot blackmail him. Understood? Sufficient. Similarly, the patient doesn't have HBe, any virus doesn't have HBe anymore. It cannot. It's not showing anti-HBe. So you are having anti-HBe, and this cannot attack the HBe. So you cannot attack the virus, and suddenly the virus will start replicating again. So this patient, despite being anti-HBe negative, will start replicating. You will have anti-HBe positive because it is already there in the blood. Your anti-HBe is negative. You think this patient should be not having replication, but no, this patient has a mutant variety of HBe. So this patient, you check HBe DNA titers, the DNA will be very high because it is replicating. It is called reactivation, and because there is inflammation, you will have elevated LFTs. Everything is similar, but HBeAg is negative. So now you will go to resolved hepatitis. Resolved hepatitis is when, until now, the HBsAg is also positive, right? When anti-HBsAg appears and HBsAg disappears, you will get resolved. In these patients, HBsAg is negative, HBeAg is negative, HBV DNA titers are not detectable, and there is no inflammation also. Your liver enzymes are normal. And only thing that will be positive is anti-HBs, okay? Because everything has resolved. That is about the inactive carrier phase. You will have a similar picture in patients who are vaccinated. In vaccinated patients, you give anti-HBS, HBS. Okay, you want the body to recognize the HBS and develop an antibody for it. So these patients will develop an anti-HBS, similar, effectively like resolved hepatitis. So this anti-HBS is protective against further infections. So that is why you give it for infection, for vaccination. So that's about it. Today we have discussed about acute hepatitis B, chronic hepatitis B, and how you detect a chronic hepatitis B. So treatment of hepatitis B, hepatitis C will be seeing in the next class. Okay. Thank you.